do a great program today.
And welcome, Dr. Parikh, also. We are starting to let our guests in, and we're going to start with our program here because we have a very special guest with us, and we want to give her plenty of airtime. So we thank our sponsors and our incredible volunteers, our wonderful operations team, and we promise an excellent show of talent and passion here today. Next, please. Most of you know me, and I am happy, so happy today to have a ridiculously packed agenda, which I'm constantly criticized for doing, but you can't say no to this level of talent. We have the wonderful Janet Wright, the head of cardiovascular disease for the Centers for Disease Control, with us, founding director of Million Hearts. And we will be introducing the rest of the team that we're going to hear from today in a few minutes after Janet speaks with us. I'd like to share with you a couple of slides. Next, please, just to give you a little bit of context of what inspired us to do this gathering of women physician scientists. So we really want to emphasize that in women's childbearing years, they are constantly reminded that they should get screened for breast cancer and cervical cancer and be very aware of those things. But they don't have the awareness that we plan to bring to you in our 292nd University of Best Practices, that actually heart attacks, strokes, and hypertensive diseases are a major threat to women in their childbearing years. Just as an example, cervical cancer compared to ischemic heart disease in that first line of the 35 to 44-year-olds should be something that we are really emphasizing with care teams to make sure that we do raise the awareness and we start doing screenings for those things that do kill people. So in the Right Care Initiative, we emphasize working with numbers and driving policy with the numbers. So I'll just say that in the 35 to 44-year-old group, the combined risk of hypertension, ischemic heart disease, and cerebrovascular disease adds to 8.2 per 100,000 deaths in California each year. And that is, right up there with breast cancer and cervical cancer combined. Then by the next decade, I think there starts to be more awareness, but what we would love to do is advocate that when women are in their childbearing years, even before age 35, they start getting their risk scoring and awareness to know their numbers to prevent preventable heart attacks and strokes. Next slide, please. And this slide is becoming very famous from Steve Sidney's work in the CARDIA study of coronary artery disease among the young. And I'll just say that in the 33 to 45 year range, when they did a population scan in this special group that they've been following since 1985, they found that women in the ages of 33 to 45, 1 in 20 of them already have coronary artery disease, subclinical, and it is life-threatening. So we need to raise awareness, and that's what our wonderful women's writing group is going to do with us today. And with that, Janet, may I hand the baton to you and just say thank you for joining us. Thank you for inspiring us all these years. We will never forget that you came to the Right Care Initiative several years ago and spent a lot of time with us when you were the director of the Million Hearts. So thank you for your continued leadership on this issue. And with that, I think rather than going through her bio, we should just give Dr. Wright the floor. And thank you so much, Janet, for being with us.
Oh, thank you, Hattie and Dr. Palmer. I have deepest gratitude to you all, the entire Right Care Initiative leadership team. My job is to speak quickly and hand it over to this all-star panel. But I do want to take a moment to say, I'm a longstanding fan of the Right Care Initiative, have been and always will be. I'm especially delighted to help kick off this afternoon's powerhouse session on a topic of great importance. It's one dear to my heart and one led by my esteemed colleague and friend, Noelle Berry-Mers. Noelle and I first bonded. Noelle, I don't know if you know this, but we first bonded in the CCU at San Francisco General in the 80s.
Yeah.
In the 80s, I was a cardiology fellow, she a resident. I believe I was wearing red cowboy boots at the time.
You were?
That was a reaction. that was a reaction to an unexpected and second pregnancy, right smack in the middle of my fellowship. Family planning was not my forte. Following our San Francisco days, I went north to Chico. Noelle went south to LA and continued in an extraordinary career as a clinician, a scientist, a researcher, a mentor, and a compelling advocate and actor in women's cardiovascular health. She continues every day to inform and inspire people across the country and around the globe, and to shape and to fuel the direction of this critical field. She's joined today by a cadre of experts in women's cardiovascular health, many of whom, fair warning, I track avidly to enhance my own understanding and to inform and guide the work we do in the Division for Heart Disease and Stroke Prevention at CDC. I cannot wait to hear their presentations today. I will close with sober news that all of you know, but it is imperative that we keep it uppermost in our minds and in our hearts. We are losing ground in the battle against cardiovascular disease. While this might not apply to California, it applies to the rest of the nation. This is a largely preventable plague. You all know how to prevent it, and you've proven your results. These national trends in heart disease and stroke mortality and in mortality due to hypertension are going in the wrong direction. These deaths are occurring in people at younger ages, as we'll see more about today. But these people are our parents, they are our caregivers, they are our workforce. So we've got a lot of work to do. I'm looking forward to rolling up my sleeves with you, and I will turn it back over to you, Hattie. Again, thanks so much for the chance to join today.
It's so lovely to have you with us, such an inspiration. And we will keep you posted on how our women's writing group comes along. Dr. Noelle Berry-Mers, who leads women's cardiovascular disease at Cedars-Sinai, has such a wonderful reputation that we won't take time away from her presentation by going into her beautiful background. But needless to say, as the director of the Barbra Streisand Women's Heart Center at Cedars-Sinai, she has a national and even international presence in leading awareness about what we need to do to better protect women from preventable heart attacks and strokes. And I have to say, it was Dr. Berry-Mers that looked at the slide behind me in the aqua, where the women's heart attack hospitalizations came down so substantially, so quickly. She said, well, that's because when guideline-directed care is followed, women are the first beneficiaries because they don't usually get that care. And with that, I'd like to say, Noelle, bless you for leading our women's writing group. And I hand the baton to you to facilitate the meeting. Thank you.
Excellent. And Hattie, thank you as always for an amazing agenda. Thank you, Janet. I do have very fond memories of standing with you in the CCU, bending over patients. We think we saved a few lives. And but now we can do even better because this type of policy work and having a friend and colleague at such a high federal level, we're just so excited to transform and do the things that we know work now at a policy level. So I am chairing this writing group. We haven't written anything yet, but Hattie wanted me to remind us that we are going to be writing. And again, it will be a statement that hopefully will drive policy. And as Hattie says, preferentially save women's lives. Not that we also want to save men's lives, but men are more often getting guidelines therapy. So the biggest gaps, as we saw from Hattie's slides, are in women right now. Let's advance the slide. And so I was just asked to give an overview. Of course, we always disclose. I do a lot of research. These are related to research issues, not to today's content. Next slide. So I thought I'd just walk us through. CVD is on the rise, as we heard from Janet and Hattie. It's now the leading killer in pregnancy, and this was an area of interest to our group. It is the major health threat related to the pandemic. It's going to get worse before it gets better. The Women's Heart Alliance is an organization that I am on their medical advisory board. I'll tell you about them because they are working on policy at a high level and what I think we need to do. Next slide. So trends in cardiovascular disease mortality, and this precedes the pandemic. So this is women and men from 1979 to 2018. And what you can see are captured in the bullets. The trends are not good. They were getting better. You can see the red line here is CVD mortality for women. The blue line is for men. Women and men, historically, this is the leading killer. There was a period of time in the late 80s, 90s through the early 2000s where more women were dying than men. We had initiatives, the Red Dress campaign, the Heart Truth campaign. We worked hard on these guideline campaigns and it looked like it was working, right? That female mortality preferentially fell even more than male mortality. But it's going up again. And it was going up even before the pandemic, unfortunately. Declines in women are less, and particularly they're less in women that are of diverse race and ethnicity. Next slide. I'm sorry, I got my arrows going. So just keep clicking. So here's data from New York City, actually, where they can get really granular. So the blue arrow demonstrates that young men, including young Black men, men of color, the blue line shows their mortality is going down. And this extends through the early 2000s. And yet the two red bars show that female young mortality is very stagnant. And then the arrow that's pointing up, that those are women of color. Young women of color are actually more likely to die now of cardiovascular disease. And this is very good data. You know, it's sometimes hard to get sort of rigorous data, but this is super good data and quite reliable and reflects what we're seeing in the larger data. Next slide. So we know that there are racial and ethnic disparities. We know that this is historically true, and this is a good time. There's so much attention now due to SES as well as racial and ethnic disparities that to call this out and really start to make a difference will be very important. There's disparities are particularly true for diabetes. And diabetes is a stronger risk factor for women for CVD than it is for men. Diabetic women equal now the risk of men. And we think at every age, men are more likely to get premature CVD. A diabetic woman basically has the same risk as a man. Next slide. And it's particularly worse for women of color. So the Virgo Registry was a big study sponsored by our National Heart, Lung, and Blood of women and men less than 50 years old having heart attacks. And it was designed to try to understand why these young women were 2 to 4 to 5 times more likely to die than a young man. And it turns out it was pretty standard stuff. It was hypertension, it was chronic kidney disease, and importantly, these young women were much less likely to be treated before the heart attack for their diabetes, for their dyslipidemia, and for their hypertension compared to an age-matched man. And that's depicted in this central figure. Next slide. So why are young women less likely to be treated? Our Women's Heart Alliance did a survey of women, representative community women. Hang on, go back. I know it's gross, but you know what? Sometimes you have to shock people to sort of get somebody's attention. When we did this, trying to understand the Virgo results, it became very clear that women didn't go into the physician until they lost a little weight. So they knew they were going to be fat shamed. And men were fine, and including overweight men were like, yeah. And then the physicians were much more likely to tell a woman to lose weight than to treat her diabetes or to put her on a statin, both of which are guidelines, where the men got plenty of guidelines therapy and were much less often told to lose weight. So we have a big problem of cultural issues and gendered issues that we need to do a better job deploying our guidelines and getting physicians on the page. Next slide now. So we also, of course, have this perception, and this continues, even though we've made inroads, it continues not only in our patients, but among physicians, that husbands get heart attacks, wives and women do not. Next slide. This is still pretty textbook. Pick up any textbook, watch a television show, and you will see men having heart attacks. You will not see women having heart attacks. And this would be another thing that we could do as policy. Get Shonda Rhimes to, to start to depict real life. Next slide, because this is what women's heart attacks look like. And this was an important, many people have contributed to this, but our women's ischemia syndrome evaluation really painted the picture of what we need to be perceptive to. There was a very interesting study where female emergency room physicians seemed to take better care. They had a lower mortality of their female patients, probably because they know about this poster. Next slide. So I did want to talk about maternal mortality, and I wanted to profile this as an example of something that we could do as a writing group with the right care. The state of California, and this was the California Maternal Quality Care in the CDPH, recognized that we were seeing a rising rate of maternal mortality, which depending on your definition, but it can be up to 1 year after the birth, doesn't always have to happen during the birth. And that cardiovascular mortality now was the leading killer of pregnant women. It wasn't bleeding anymore. So they said, wow, we better do something about this. Next slide. So looking from 2002 to 2006, they were able to identify, break down what was this cardiovascular disease mortality and how much of this was preventable. So much of cardiovascular disease, we have the tools, we know what to do. We can save lives. So this is a breakdown, again, demonstrating the surplus of African-American non-Hispanic deaths compared to the other groups. Of course, the other groups have it as well. But this was, pretty important. And it was really reflective of national statistics that we were seeing where Black women were much more likely to suffer death during a pregnancy, including Serena Williams, one of our tennis stars. She almost died. So this, sometimes these celebrities making news is a good wake-up call for all of us. So next slide. So about half of this is cardiomyopathy, which again is something that is either, related to the pregnancy that comes on, although that's still fairly rare. Sometimes the pregnancy unmasks things called dilated cardiomyopathy or a genetic condition, typically hypertrophic heart disease. But both of these are treatable. And so that's the reason that breaking this down was important. Next slide. And then here's kind of the other, a little bit of this, a little bit of that, and a little bit of this. And again, these are treatable. Pulmonary hypertension is treatable. Aortic dissection, if you can diagnose it, is treatable with surgery, et cetera, et cetera. So one of the toolboxes for this CMQCC is designed to educate OBGYNs, but also the nurses, the nurse practitioners, the doulas, the technicians, how to recognize. I mean, for example, one of the kits says, new onset asthma in pregnancy is rare. Think heart, heart failure. And, a good nurse, a good tech, a good OB is going to pick up on that. Next slide. So one of the things that they made the point over and over again is that only 2 women entered pregnancy with known cardiovascular disease, and that included hypertension. And so to our writing group's point, we really need to get back on the stick about every adult needs to have their blood pressure checked every year. And if they have signs and symptoms, they need to be seeing a physician. Next slide. So contributing factors, these are the presence of other underlying medical conditions. Obesity, of course, is a problem, only 31%. That's better than the national average. The women do delay in seeking care, similar to our survey. So we need to do a better job educating them as well. And then the lack of recognition of CVD symptoms, that's education for our allied healthcare professionals and our GYNs. Next slide. So I wanted to say just a few minutes about the pandemic. We anticipate now 3 curves of death and morbidity. The first wave, of course, was the COVID-19 cases. The second wave is delayed care. Heart valves that should have been replaced, hypertension that should have been treated and come in. And we're dealing with that right now. Many hospitals are full, not so much of COVID, but just deferred and delayed care. And then the third wave is going to be increased chronic disease, diabetes, hypertension, cardiovascular disease, because of weight gain, lack of physical activity, and lack of attention to proper nutrition. So unfortunately, these curves that were already headed in the wrong direction are likely going to get even worse. Next slide. This is a percentage of people who gained weight during the pandemic by gender. It's pretty scary. We talk a lot about the freshman 15. There's a COVID 15. And that is a substantial amount of weight that, again, will drive diabetes and hypertension. Next slide. A larger share of women have gone without healthcare services during the pandemic. And this was particularly true of women in fair and poor health. And you can understand why. I mean, they don't want to go out. They don't want to get infected. They don't want to sit in a doctor's office or a hospital emergency room. This is Kaiser Family Foundation data. And again, why a focus on women, I think, is just so relevant at this time. Next slide. So the Women's Heart Alliance was started by Barbara Streisand. She heard a call to action. Her foundation manager had seen what we were doing. And one evening I got a call, please hold for Barbara Streisand. And we chatted for about an hour, and she decided to raise money to endow our center. And it is endowed for education, research, and advocacy policy. And this was the slide that I showed her that evening, because this was our scary, scary time in the early 2000s, where women were just dying. So thank God, and she's a real advocate. She's a strong woman, super bright. She can do everything. Yeah. Next slide. So this is called the Women's Heart Alliance. It's considered an umbrella organization to just help everybody, help the American Heart Association, help the American College of Cardiology, help the Right Care, Right Initiative, help the California Quality Obstetrics, meaning if there's something that needs to be done at an advocacy level, if there's polls that need to be taken, if there's data that needs to be put together and advocated, that is our job. Next slide. Our mission statement is to raise awareness, encourage action, drive support for women-focused research and treatment to fight women's heart disease. We empower women to fight against heart disease. This is a very active campaign. We're not shaming people. We're not telling them that they didn't eat enough carrots. We engage doctors in improving through education, diagnosis, and treatment, and we garner support for policy changes and women's heart disease funding. Next slide. This is the survey that I talked about, done very professionally by a professional think tank survey organization. And we entitled it American Women Speak Up About Heart Health. Next slide. We published this in JACC, Journal of the American College of Cardiology, at the time the highest impact factor, most important journal that cardiovascular specialists as well as primary care docs read. And you know, the facts were once again alarming. Less than half of women knew that cardiovascular disease is the leading killer. 1 out of 4 women said it was embarrassing to go to the doctor because they were going to be picked on about what they weighed. Only 40% said that when they did go in for routine checks, the doctor included anything that was related to cardiovascular disease. So, you know, women are told to get their mammograms and their pelvics and PAPs and sometimes a bone scan, but who's talking about cardiovascular disease? Only 39% of primary care physicians ranked this as a priority. The most highest priorities among primary care and among specialty physicians was weight management and breast health. So that just tells you how far we have to go. Next slide. So I did want to, this has a link on it, and we have a little spot. Yeah, okay, just keep going. Yep. All right, so this was our Lady Killer campaign. And then maybe it's on the next slide. Let's see if the link works. Yeah, if you click on that, it's just a real short video. Let's see if it's gonna go. Maybe not. You know, there are all sorts of campaigns. If you think back to Betty Ford and Nancy Reagan standing up and telling the public that they are breast cancer survivors, please go get a mammogram. That's celebrity. And mammography rates are well over 75, 80%. They just went up. So we have these different PSAs, and it's probably not going to work, but we can send it out later. Oh, maybe it's going to work.
I will be right by your side. If I can't find the cure, I'll fix you with my love. No matter what, you know I'll fix you with my love. And if you say you're okay, I'm gonna heal you anyway. Promise.
Yes, women can have it all, including heart attacks. Know the signs. Heart disease is the #1 killer of women. Get heart checked.
Thank you. Fabulous. And thanks for the technical assistance. You know, that kind of stuff should just be playing all the time. And we have similar things for physicians and healthcare providers. So Hattie, let me close with that. I didn't run over. Okay, really nice. I now would like to, it's a great pleasure to introduce Dr. Jessica Nunez Ibarra, who is chief of our chronic disease control branch in the CDPH. She is listed here, her degrees, and this is my first meeting of her, but we're just delighted to have her as part of this group. And she will now give our presentation, State Action Plan for Heart Attack and Stroke Prevention. Jessica, thanks for joining us. You're on mute.
And also say, while we wait for Jessica to join us here verbally, that Jessica's been a huge ally of the Right Care Initiative for probably a decade now. We love working together, and I'm just delighted to be able to introduce you to Noelle Barrymers and our Women's Writing Group. Jessica, thank you for being with us.
It's my pleasure. Again, so thrilled with the presentation just presented and the great reach and the dedication. It's very exciting. So let me just, in the few minutes that I have, share with you an update that I think is important to the group that will be an action plan for us. Next slide, please. Again, no disclosures or conflicts to report. Next slide. The views are my own. Next slide. I work at the California Department of Public Health, and I like to always remind folks that public health is what we as a society do collectively to assure the conditions in which people can be healthy. I stand by that because we're only effective when all of us come together, and that's exactly what this group is doing. So we're all engaged in this, and so it really, it's precious. Next, please. What do I do at the California Department of Public Health? I'm chief of the Chronic Disease Control Branch. We want to work with all of you to prevent and optimally manage chronic disease. You can see there the areas of work that we focus. Next slide. I wanted to list for you all currently the programs that I, with a very wonderful group of people, including Dr. Taylor, who will be presenting later, which we are very fortunate to oversee here in California. We do a lot with little funding, with few staff, but our work is just so important for all reasons already described. The California Alzheimer's Disease Program is in the limelight right now. We're very excited about some new funding for the areas there, including new research grants, various pilots that we have, training, really exciting times. We also are privileged to be rolling out a farm worker health study with the University of California, Merced. That's underway, more news in the coming year. Again, we also work on heart disease, stroke, and diabetes prevention. I'm going to focus in this update on the California Cardiovascular Disease Prevention Program, but we also have Prevention Forward, which is federally funded, and we work on diabetes as well as cardiovascular disease. We think about direct services to women and have a small grant for a clinic in San Diego, the Well Integrated Screening and Evaluation for Women across the nation. Wise Woman is the term. We also administer in our branch the California Preventive Health and Health Services Block Grant. We also oversee some funding and work for adults that encounter sickle cell, and there's a network of folks that make sure they get the services and support that they need to survive into older age. And we have a workforce development arm where we have a residency program in preventive medicine, public health. We also have and train future epidemiologists. So there's a lot in my branch, exciting work, lots of opportunities. Next slide. But what I wanted to bring to this group is to just, again, make you aware that we're going to be updating the master plan. Some of the things that are coming up for us to think about regarding this historic document, which was very important in this past decade for heart disease and stroke prevention and treatment, is understanding that we're bringing a steering committee back together and that work and convening will be happening in the coming quarter. Also, we are going to change the term master plan to an action plan, thinking about fewer objectives and activities so that we can ensure impact, really looking at health equity and some of the items that were discussed today. Also looking at comprehensive medication management as a possible way and strategy with team-based care considerations and bringing the pharmacist to the care team, community health workers, others to really engage with us to the degree that we can sort of stamp out, as was described earlier, heart disease. We also will continue to engage with many of our stakeholders in this work through our Healthy Hearts California group. And again, some real exciting pilots in Riverside County underway to show that comprehensive medication management will work in a post-stroke group of folks that will have been discharged from the Desert Regional Medical Center in Riverside County. Lots of good work happening there. Next slide. For information, feel free to reach out to me. This again is meant to be just a quick announcement about what's underway and a very specific mechanism that each of you will have as we move forward. I'll be in constant contact with Hattie and many of you to ensure that we do the best for the action plan this coming year. Happy to take any questions. I'll turn it back to Hattie. Thank you.
Thank you so much, Jessica. It's just wonderful that you carved time to be with us. What a great group of women scientists that we have together today. Next, we have with us Dr. Nisha Parikh. Thank you, Noelle, for introducing our next guest.
Okay, thank you again. And this is just such great work. It is with pleasure I introduce Dr. Nisha Parikh. She is also a member of our working group. She is a clinical cardiologist, cardiovascular care and prevention center, pregnancy and cardiac treatment program, as well as an associate professor of medicine at UCSF. You can see her credentials here on this PowerPoint slide, and she will now present preeclampsia and pregnancy-related CVD issues. Parikh. Nisha, sorry.
Oh, that's okay. So I have no relevant disclosures to the talk, and I'm just seeing if I can move the slides myself, but it doesn't look like it. So next slide. Okay, I first wanted to introduce this concept that really underlies a lot of the work that we've done in my research lab, and that's really thinking of pregnancy as a cardiometabolic stress test, so that if you have the normal population of women depicted in the blue dotted line, she goes sort of through her life and then experiences a cardiometabolic blip around the time of pregnancy. And I'll kind of explain a little bit why in terms of physiology in a little bit. But she never really crosses that vascular threshold. And that's the horizontal black dotted line on the slide. With her next pregnancy, she experiences another blip and then would go on to develop cardiovascular disease later in life. And if you contrast that with the woman who experiences a complicated pregnancy, complicated by something like preeclampsia or hypertension, gestational diabetes, then that person will actually cross the horizontal dotted line of that vascular threshold during the pregnancy. And we believe she'll go on to develop cardiovascular disease earlier in her life. Next slide, please. So, and if you just go back one, and okay, you can go ahead, go forward. So yeah, this is just sort of depicting it in a different way, thinking of pregnancy and that entire time period as a stress test. And that stress test really can unmask cardiovascular disease in the mother or in the baby, depending on what the particular complication is that's seen. And although it's not a focus of my talk, it's true that if you are born in a pregnancy that's complicated by a cardiometabolic disease, you yourself will be at risk for later CVD. Next slide, please. Next slide. We recently summarized all of the vast literature on this topic of adverse pregnancy outcomes in cardiovascular disease in a statement that was published by the AHA recently. Next slide. And this was sort of the take home, which is that several adverse pregnancy outcomes have had really strong evidence of links with atherosclerotic cardiovascular disease, including coronary heart disease, peripheral vascular disease, and stroke, as well as in the case of hypertensive disorders of pregnancy, heart failure. And this is, although a summary slide, it really summarizes meta-analyses that span literally hundreds of studies now. So there's been quite a bit of work. The other adverse pregnancy outcomes that we felt had at least a strength of evidence of A or B based on those studies were gestational diabetes, preterm delivery, having a small for gestational age baby. Large for gestational age had one large study that showed a link, placental abruptions and miscarriages. Next slide, please. So although our statement sort of concentrated on this maternal and fetal outcomes sort of bucket here, it's true that there's probably more layers to this sort of onion, if you will, and that encompasses pregnancy itself as well as reproductive health and pregnancy. And I'll show you some of our work in this area. Next slide. The way that I generally have thought about this and sort of come to think about this, I should say, is that if you look at all of these pregnancy and reproductive health factors, they're really sort of overlapping. They're correlated with one another, either in a negative or positive way, and they're not really independent. But it's true that if you look at sort of each cluster of pregnancy or reproductive factors, they're actually linked with cardiovascular disease. And so I just wanted to talk about some of these circles briefly. Next slide. And if you sort of accept that that's true, and hopefully by the end of the talk you might, when I show you a little bit of data, then I think that we're really missing a couple opportunities for primordial and primary prevention of cardiovascular disease. One is sort of a area I'm not going to concentrate on in this talk because of time limitations and your attention limitations, but there are probably in utero effects of adverse pregnancy outcomes on the next generation, whether you're born as a sort of female or a male child. That's true if you're born to, say, a pregnancy that's been complicated by preeclampsia or gestational diabetes. But this pink arrow is really where I think this talk sort of falls in line, which is that there are, if you're able to really understand a woman's relevant reproductive and pregnancy history, then you have a snapshot into her cardiometabolic health. And I think you can institute, in many cases, primordial prevention or primary prevention early, aggressively. And it's true that 85% of women experience pregnancy, but I'm going to show you some data that nulliparity itself is a risk factor for CVD. So the other 15% experience nulliparity. 15 to 20% of women have at least one adverse pregnancy outcome, and certainly 100% of women have a reproductive history. 100% of kids have a birth history. So I really think that this paradigm really includes all of us. Next slide. So I want to talk a little bit about the maternal and the fetal adverse pregnancy outcomes, and the ones listed on the slide have been linked to cardiovascular disease. Next slide. So if we think of hypertension in pregnancy, it's really just to kind of bring it back home to the physiology in case that's of interest to anyone. Why would this sort of unmask something? Well, if you think about the implantation of the placenta into the maternal myometrium or the uterus, with preeclampsia on the right, there's a shallow implantation, and the spiral arteries of the placenta don't actually implant fully into the into a woman's uterus. And we believe that sets off a cascade of events that leads to basically, in some cases, preeclampsia, a sort of, acute cardiac condition. Next, or if you click through, you can see this in the placenta as an infarct, or you can see the arteries in the placenta as being hypertrophied, like on this path slide. You can click through. And the maternal factors that lead to preeclampsia or hypertensive disorders of pregnancy include hypertension, having excess BMI,
It seems like we're having a little bit of a technical glitch where Dr. Parikh is frozen. I wonder, Dr. Barrymers, if you could talk a little bit about this issue while she comes
Yes.
back on.
Yes, so hypertension clearly is a problem. About half of the cases that come in, they actually were hypertensive before the pregnancy. The pregnancy exacerbates it, but then there is this, gestational onset of hypertension, and it is not pretty, and it can turn into the preeclampsia, which actually can kill women. Although again, as we talked about before, the OBGYNs are pretty good now at managing preeclampsia. They're very good at managing in the hospital gestational hypertension. So women don't tend to die from this very much anymore. There's such a high awareness. Maybe advance the slide. Yes, so when you have a history of preeclampsia, your risk future of things like being hypertensive goes up within 5 years, and then having early onset cardiovascular disease from some of these large registry studies that are typically from Sweden, or Scandinavia. Also, though, our Nurses Health Study, Joanne Manson, shows these data. And the relative risk you can see is twofold. So you take what, an average young 45-year-old woman who had a preeclamptic pregnancy when she was 25 or 35, she is at much higher risk of future cardiovascular disease, and that would include hypertension, heart attacks, strokes, etc. Next slide. Gestational diabetes, in many ways similar. Women come into it possibly insulin resistant and nobody knew about it, possibly related to obesity. Obesity is a stronger risk factor for all of these issues during the pregnancy gravid state. Obesity is not a big risk factor for cardiovascular disease in general if it doesn't drive hypertension or diabetes, but it is more powerful during pregnancy. It occurs in 2 to 8% of pregnancies in the United States. That's a lot.
This is such a wonderful women's group. And Nisha, we lost you technically.
I know. I don't know what happened.
But she's back.
And Noelle.
Thank you, Noelle. I actually would like to give the talk.
We're a good team. All right, you're
okay.
Thank you, Noelle.
Hopefully I won't drop off again. I apologize. Next slide. So this just illustrates what Dr. Barrymers was talking about, that gestational diabetes is linked with cardiovascular disease from a large Canadian registry. Next slide, please. This is work by Jacqueline Desjardins. She's one of our chief cardiology fellows this year. And in her work with the California claims database HCUP, she studied placental abruption and found that it was linked to heart failure in women in California. And this was independent of hypertensive disorders of pregnancy, but probably synergistically related to both hypertensive disorders and preterm birth mediated the effect. Next slide, please. This just sort of reminds us that small for gestational age is linked with cardiovascular disease. And if you click through, you can see that if you have a very small baby who's born very preterm, they actually have threefold excess risk of CVD compared to the term baby born at a normal size for gestational age. And this is in 1.3 million women in Sweden. Next slide. This is work from Donna Parker, and she published on pregnancy loss linked with cardiovascular disease from data from the Women's Health Initiative. And this work was really in line with several other studies, and there's been a really nice meta-analysis done that shows links between both miscarriages as well as stillbirths and cardiovascular disease across many studies. Next slide. This is work by Philip Paul, who was a cardiology fellow with us, and this was funded by the ACC Merck grant. He looked at what factors could be driving some of that association and found that women with pregnancy loss had higher BMI, a higher prevalence of hypertension, and other cardiometabolic risk factors that potentially predicted the pregnancy loss. And so it's possible that that mediates the effect. Next slide. We also used data from the Women's Health Initiative some years ago and confirmed that these were independently associated. So stillbirths, miscarriages, and then also irregular menses and lack of breastfeeding were linked with coronary heart disease in these women. Next slide. I want to talk briefly about pregnancy per se and cardiovascular disease and how those are related. Next slide. So you can just click through here. There are many physiologic changes that happen in the course of a normal pregnancy that are linked to cardiometabolic health. There's changes in vascular function, in hemostasis, so women are more hypercoagulable. We become more insulin resistant with pregnancy, obviously have more adipose tissue deposition, and we have changes in our hemodynamics, including an increase in our preload or volume in our bodies, a decrease in our afterload or resistance, and we also have an effective shunting of about 25% of our circulation during certain points in pregnancy to the baby and the placenta. So what we wondered, next slide, is if pregnancy is linked to cardiovascular disease in any sort of like linear way. So we looked at this in the Swedish population registers and found again among 1.2 million Swedish women that that number of pregnancies was linked to cardiovascular disease with a J-shaped association. The nadir of risk was at 2 pregnancies with a little bit of a sharper upslope once you reach the 5 or more pregnancies. Next slide. We also looked at cardiovascular hemodynamics in the MESA cohort and found that some of those hemodynamic changes that I mentioned on the slide previously might be a little longer lasting. So this was cardiac MRIs in women at age 60. Turns out they had bigger volumes at age 60 and somewhat of a drop in the ejection fraction, an increased LV mass as well as you sort of accumulate with each pregnancy. Next slide. We looked also at the EKG in the Women's Health Initiative and found that similarly, if you had 5 or more live births versus 0, you had an increase in your PR interval, and that often tells us how big the atrium is, and also some changes in your QT interval, which is also another electrical remodeling interval. Next slide, please. And then this is work by Philip Paul again, and he's now an interventional cardiologist at UNC and was, obviously a fantastic fellow. He showed that that naliparity had an association with heart failure with preserved ejection fraction or diastolic heart failure, such that women had a almost 3-fold excess risk of that condition. And so we don't know what drives that, but that's a really interesting finding as well. Next slide. So I think we could summarize that pregnancy is related to cardiovascular disease in some way, even if it's through confounding factors we weren't able to account for, both cardiac myocardial and electrical remodeling. Next slide. Just briefly wanted to talk about some reproductive factors that are linked with CVD, either protectively or the other way. Next slide. So, and next slide. So I'd shown you this. We were interested in this sort of left-hand side of the J-shaped curve. Why was it that women with 0 or 1 pregnancies had increased risk of CVD, even though it was modest? So we hypothesized this could be impaired fertility, maybe polycystic ovarian syndrome, thyroid disease, maybe depression, maybe some psychological factor, excuse me. Next slide. And there had been this this prior work showing in both the Nurses' Health Study and Kaiser Permanente that menstrual irregularities in women predicted coronary heart disease and CVD death, maybe driven by body mass index. Menstrual irregularity was also a proxy for polycystic ovarian syndrome, and it's related to infertility. So we felt that those things were enough interesting prior data to look at this next question. Next slide, please. So we looked at years of subfertility, and we didn't call this infertility because these women went on to have a successful pregnancy in Sweden, and found that if you look at just age-adjusted rates of cardiovascular disease, they seem to have some sort of dose-response relationship, at least in an unadjusted way, with cardiovascular disease. But we found that if we looked at these different categories, it was really just the women who reported 5 or more years of subfertility. So really that extreme phenotype that gave an excess of about 20% hazards of developing CVD on follow-up. Next slide. Breastfeeding. So here's some good news. Here's a protective factor and something you can do and intervene upon potentially. Breastfeeding actually reduces cardiovascular disease, and this is work from Dr. Bimla Schwartz and also Dr. Jacobson in 2 different women's health cohorts. Next slide, please. So, and if we sort of click through now with this understanding, we could see that if you start to fill in a little more this concept of the cardiometabolic stress test, there are factors in both the baby and the mom that there's now sort of large bodies of literature on that kind of hone in on exactly what those factors are, and if you're really thinking about a positive or negative stress test. Next slide. So what can we do to prevent CVD? Which risk factors are important, and how can we start to target them? Next slide. So this is also from the AHA statement published recently, and this is sort of summarizes the data on which adverse pregnancy outcomes are linked to what actionable cardiovascular disease risk factors: hypertension, diabetes, and dyslipidemia. And what it appears is that, based on the data, is that hypertensive disorders of pregnancy are linked with probably the most robustly with blood pressure elevations, with diabetes or hyperglycemia, and also with dyslipidemia. So there's lots of actionable steps you can take if you have a woman who has that condition. Gestational diabetes has been linked as well, and you can sort of see that the other factors have been, some of them linked more convincingly and some less so. I think it's fair to say we probably need a little bit more evidence for some of these adverse pregnancy outcomes and their later links with CVD. Next slide. So this is sort of a lot, but it was the summary that findings and implications based on that data. Generally, that those tables I showed you, that there are these key APOs we should be taking in our history, when we have women and we're trying to risk stratify her for CVD. And primordial prevention of CVD risk factors are important in these women. Adopting a heart-healthy diet, increasing physical activity, starting in the postpartum setting and continuing through the lifespan. Breastfeeding and lactation can lower a woman's cardiometabolic risk. We also talked a lot about how there were race ethnic disparities, such that a higher proportion of Black, Asian, and Hispanic women experience adverse pregnancy outcomes with more severe presentations and oftentimes worse outcomes than white women. Next slide. we talked about how healthcare systems could address some of these and really transitions so that if you really had a handoff that was a little bit more robust between the OBGYN and the primary care doctor, and then maybe a cardiologist if she needed to see one, that would be helpful. Right now, we really have a 6-week follow-up postpartum, and then a lot of women are lost to follow-up at that point for their own health. They'll sort of, take the baby for the baby's health to those checkups. But 6 weeks is all we have right now for women in the postpartum setting. So what if we were to extend that time frame, 8 to 12 weeks, 6 months, and 12 months being those next checkups where lifestyle modification could occur? Next slide. And I think Dr. Barry Mertz really talked a lot about maternal mortality disparities. So, but it's true that that those exist, and they're quite stark. Next slide. And this has been featured in the press, as well as the scientific press and the lay press. The next slide. So how do we tackle some of these things? This is work by Joyce Giroje. She's another one of our Stellar Cardiology Chief Fellows, and she wrote, along with me, a review article on the issue of health disparities in Black women during pregnancy in the peripartum setting, and really kind of pointed to a lot of gaps in knowledge, for instance, but also really the need for a comprehensive community-based approaches and approaches to tackle implicit bias and structural racism to really, start that dialogue with healthcare professionals and patients to get at some of these disparities. Next slide. So in conclusion, pregnancy, maternal, and fetal outcomes and reproductive factors predict CVD, and the childbearing years are important for both primordial and primary prevention. Thank you.
We just love your work, Nisha, and we so appreciate that you've joined our women's writing group. I know that people have lots and lots of questions. I would love to have Katrina Taylor, who is our state's Chief of Health Information and Statistics section for the Chronic Disease Control Branch of the California Department of Public Health, who will be speaking next. Just maybe ask you a question or shed a little light on what you've just presented. And you're muted, Katrina.
Okay, I'm sorry, I missed your question, Hattie.
So Katrina, I wonder if you could talk, comment on what Dr. Nisha just presented about the, terrible disparities of negative outcomes for African-American women in their pregnancies. I know it's been a passion area of yours and you're sharing lots of resources with us, but I thought it would be good if the two of you could have just a little bit of dialogue while we have Nisha with us.
Okay, so I definitely thought that, her slides were really great, and she brought up some really good information, especially about the the care continuum, what to think about while you're pregnant, because especially for African-American women or just women of color, a lot of times, we don't know what to look for or, even what to expect during the pregnancy as far as cardiovascular events, or even if you have a family history associated with heart disease and how that can impact health outcomes. And then for African-American women, especially, healthcare and how healthcare is received. I know that earlier on, Noelle had talked about Serena Williams and just, she had complications during her pregnancy. And even though, she was voicing that, initially it wasn't heard. And the good thing is that she had a survival rate with the pregnancy, but maybe, care earlier on, prevention may have been helpful.
Yeah, I think you bring up a really good point, and I think that there's a lot of sort of two-way communication that could be really useful, I think, in tackling a lot of the race ethnic health disparities. I know in the case of Serena Williams, she had a pulmonary embolus even with her prior in her prior lifetime. So she knew what it felt like. And we wrote about that in our review article, actually. And she sort of had a hard time convincing medical staff to treat her, even though she knew what she was supposed to be treated with. Very educated, had a lot of agency. And I think a lot of our patients sometimes don't feel that same empowerment. So she was able to kind of turn her case around. But I think, so I think it's important. Education's important. And I think the simple steps of like knowing your blood pressure numbers early on in your pregnancy, and maybe even before you get pregnant, is really helpful, just to know if you're at risk, if you should be seeking care a little earlier, being monitored a little more closely, like that type of thing. So some of it's simple and we know, but it doesn't happen. So.
Right.
you.
I know I was very fortunate. I mean, I won't say I was a young mother, but I was considered a geriatric pregnancy, of course.
That's what all the women say.
I am relatively still young, but earlier in my career, I was introduced to young stroke. I've never had a stroke. However, just hearing about young stroke and its impact on health outcomes, and especially for women who are pregnant. And for, women who are in their 30s, in their mid 30s who are pregnant, sometimes they're oblivious to the fact that they are at risk. During the course of the pregnancy, your body does have that stress. And, being aware of that additional stress, especially if you're part of a racial ethnic group that is disproportionately impacted by cardiovascular disease, high blood pressure, and may even have a predisposition to high blood pressure because of family history. Really taking all those things into consideration, and some of those environmental stressors that, young women or even just women of color have to navigate through, especially during a pregnancy, all that increases the likelihood for high blood pressure and, cardiovascular events such as preeclampsia, and then even after birth impacts. So even with the breastfeeding, some of those protective layers may be impacted, because if you're stressed out, you can't produce the milk.
Yeah. Yeah,
and then
absolutely.
you lose that protective layer.
It's a cycle. Yeah. Yeah. It's the vicious cycle of like when you're supposed to be nursing and like it can't happen.
Right.
And the stress that produces. And then you make a great point about just stress in general, definitely not being helpful for a lot of these adverse pregnancy outcomes, and definitely not for cardiovascular disease. So I think as providers, like as much as we can be like kind of take that extra 10 steps forward towards the patient, I think that would go a long way, honestly. Recognizing when patients don't feel so comfortable with us, honestly, and kind of just making those extra steps to solidify that trust. That's really important.
So how do you think that could be promoted? So like I know like with tobacco, they'll have like the 4 A's as a way to get, physicians to talk to the patients around smoking. What do you think needs to happen between the provider to get them in the mindset of routinely practicing that prevention for young mothers?
Yeah, that's a great question. I definitely don't have all the answers. I think like kind of constantly sort of checking our own implicit bias is important as a group, because we all work as teams. So, maybe that one person doesn't have it, but another person might. Like we work with, I do see pregnant women in my practice, and we work together as a team. There's a social worker, there's a cardiologist, there's a obstetrician, there's the nurse, the nurse, the MA, like there's, it's everyone. And I think any piece of that puzzle could break down trust and communication. So I think maybe, when I've seen it work successfully, it's when we're all talking about it, openly, and saying, hey, this is our checklist. Like we got to do this with each patient. And as much as you kind of systematize that care and recognize when people aren't so receptive and making those extra steps, those extra phone calls, like, hey, here's my cell phone number. Like if usually patients don't use it, but it sort of goes a long way. It's like an extra step you're taking towards your patient. So, yeah.
So we do have Dr. Janet Wright.
I definitely love that you brought back up team-based care. So really looking at how to incorporate the total team, whether it's the physicians, it's the, the nurses, and even possibly, the pharmacy team, or, some sort of community
Yes.
health worker that helps to navigate the patient through, the resources that are available. I think that is huge. Dr. Nunez de Ibarra kind of mentioned that earlier. We really educate our partners around team-based care, and hope that they adopt that in their practice.
So we are so fortunate to have Janet Wright with us to ask a question. Janet, are you able to unmute yourself? I see you have your hand up.
I do, and I just want to, I learned an expression when I was working in the Office of the Surgeon General. It's used by, I guess, maybe military. I'll ask Scott. But I want to foot stomp the conversation here, as Dr. Taylor raised it, and Dr. Parikh also, of hypertension in women of reproductive age, or in women during and following pregnancy. I feel like we are missing the opportunity to both detect it, to avoid overtreatment and undertreatment, and to really put the control of hypertension or its management in the hands of those who experience it, particularly given all of the downstream effects of uncontrolled hypertension, undetected, uncontrolled. So I will pose a question when I step off the soapbox. No surprise to my Right Care family that I'm on that soapbox. But Dr. Parikh, do you have any work underway looking at remote management of blood pressure, or self-measured blood pressure monitoring through any of your programs?
We don't currently have anything underway on that topic, but we have studied that issue. We've looked at giving women kind of a lifestyle coaching app with blood pressure monitors in the postpartum setting. And I'm just getting called by the Echo Lab. Hang on just a second. I'm just saying 5 minutes. So
Sorry, I didn't squeeze my question in earlier.
No, not at all. It's challenging for the reasons you can think about, but it's not impossible. And most of, I'd say that we got engagement from maybe, I would say at least 2/3 of the women around having a blood pressure cuff at home, measuring blood pressure, entering it into the app. And the app was like it's sort of like, now they're so common. There's like Noom and a bunch of other, sort of management apps for health. But this was really hypertension focused prevention. So it was like all the tenets of the DASH diet and Premier, and like the things that we know work really well, incorporated into an app that a woman could interact with blood pressure monitoring as well. And that approach worked pretty well. And I would say made good evidence for like as pilot evidence for something larger. But I would say it's true that we don't really have data on this population. The DASH diet excluded women that were trying to get pregnant or who are breastfeeding. So I really don't think there are very many women of that age group, and with the kind of lifestyle of women that women have during childbearing age. And so I don't know if we can extrapolate our findings from those studies to this group of women. So my personal bias is, why shouldn't we have more data around this to find out what the barriers are? Yeah.
Thank you.
So I see that we have our co-chairs from Silicon Valley who've just joined us. And before we, I think we can jump into this section of the agenda where our concept is to hear from these young practicing scientists and physicians who are young mothers and what they have experienced. And I would first like to introduce again our dear Katrina Taylor, who is on our technical expert group and has been a major force for good in the Right Care Initiative for many years now. We've worked on data to try to drive improvement, particularly around the capital region, but she's given us a great deal of insight and knowledge about the world of epidemiology, but our concept today for this section is really, and I'll just mention the 4 women who will be with us, and I have their bios pretty much memorized. I should say that Dr. Taylor does hold a PhD in public health from St. Louis University, a master's in public health from Meharry College, and a BA in biology and pre-med from Fisk University. We are lucky that she's joined us on the West Coast. So lucky. She's just been such a brilliant force for good. Before we hear from Katrina, I'm just going to mention that our 3 other young, amazing physician scientists that we have with us are also on our women's writing group, trying to shed light on how do we prevent future heart attacks and strokes that really are preventable. And we've come up with some great ideas as a group. So we'll also hear from Sarah Johnson, an obstetrician and gynecologist from Altabate Summit Medical Center. And she was introduced to us by molecular cardiologists at UCSF, Eveline Stock, who helps to co-lead our University of Best Practices in the Silicon Valley, along with our youngest mother with the youngest children with us, Dr. Nirali Vora, who will be also speaking with us. She is the co-chair of the Right Care Initiative, Bay Area Silicon Valley University Best Practices. She's a clinical associate professor of neurology at Stanford and helps run the Stanford Stroke Center there, as well as leading global health neurology and the adult residency at Stanford. So so I introduced the whole group, and the idea is that we're going to hear from their perspective, not only as practicing physicians and scientists, but as young mothers and what they went through in their pregnancies that help to inform what we can do for young women to help prevent those heart attacks and strokes. So let's start with Katrina Taylor, and then Katrina can hand the baton to Sarah. Thank you again, Katrina, for being with us, and I'm so glad you brought your children on the screen in our pre-session. With that, the baton is yours, Katrina.
Oh, thank you, Hattie. It's always a pleasure, and thanks for inviting me to the Women's Work Group and to be on this panel. So I will say, I was very fortunate as a what was considered to be a geriatric pregnancy. Hearing that term, initially anyway, it just, it's a little shocking. And then also puts it into perspective for you to actually think about your health. I actually did not have an adverse health outcome with either of my pregnancies. I do have a 2-year-old and a 4-year-old. However, what I was very hypersensitive about stress management and also about self-monitoring of blood pressure. So earlier, I will say like maybe around 2014, I was introduced to the Young Stroke program. It was a young lady out of South Carolina named Amy Edmonds. And she had asked me, we were at a meeting, and she was like, what do you know about young stroke? And I was like, very naive and said, not a lot. And she was like, do you know, X amount of women between this age, that are younger than 65 are experiencing strokes, and African-American women are experiencing them at the highest rate. They're disproportionately affected. And she was like, not to be personal, but have you had children? Do you have children? Because that could be a stressor in itself, just being a parent. And, I told her no. She was like, you're in the childbearing ages, so you might really want to be aware of that. And so, I started looking into the literature and also looking into just hypertension, and then also who is actually impacted by young stroke. And a lot of times what you do is it is the minority population. And the reason that they're impacted at a disproportionate rate because they have a family history. There are these environmental stressors. There is a misperception that younger people are not impacted by cardiovascular events until later in life, because the emphasis is placed on people who are older than 65 and older. And so when you add in, pregnancy, it adds a layer of physical stress on the body, and your blood pressure naturally goes up over the pregnancy. So to really be aware of, what is your blood pressure between each trimester and when you're going into your doctor's visits was very important to me. And so, my dad had a blood pressure monitor. Whenever I would go over there, which was almost on a daily basis, he would check his, I check mine. We made the team effort. And, it created a routine for, the both of us, to really be hype, to be aware and to be advocates for our own health. And then to also think about, Dr. Noel was absolutely right. DASH does not include pregnant women. So to think about, what does healthy eating look like during a pregnancy? You may have cravings. What are you actually taking in? Are you increasing your sodium intake? Are you flushing it out? Are you retaining it? What does all that look like? So really, thinking about health management, especially during pregnancy, and I really can't stress enough the stress management during pregnancy. I know that during an earlier Right Care meeting, Dr. Ziamara really talked about, meditation for cardiovascular disease prevention. And I can hugely say that my faith-based practices were huge in that. Having that time to really meditate and to think about positive influences and how to have a different outlook on situations and the environment played a huge factor in that stress management. So as a way to prevent cardiovascular disease or high blood pressure, that was a huge portion of my practice during both pregnancies. And then I would say, really thinking about the work that we do in chronic disease control branch. I'm really excited that, we had the stroke program. While the focus was not on young stroke, we did have an opportunity to have staff, within our branch, Mary Rousseff, who worked with maternal, child, and adolescent health. And they created what you see on this screen, which is, are you at risk for heart disease after having a baby or even during pregnancy? And some risk factors that you should look at in the symptoms and conditions that you should look at. And what they did was they really made this accessible, especially to those racial and ethnic communities. And they made it in a Spanish version. They also targeted African-American populations and made it where it was receptive to each group. So really looking at the resources that are available and to tap into that, having that partnership between cardiovascular disease and maternal, child, and adolescent health was huge for our branch, because then we were able to link cardiovascular events and diabetes to pregnancy. Because there is an issue with gestational diabetes and then also preeclampsia because of high blood pressure. So getting that information out on management and having those resources available to the populations that we serve is a preventive way to improve health outcomes. So I'll kind of stop right there.
So Katrina, I just want to say thank you for sharing your experience. And so you were monitoring your blood pressure before and after you were taking your meditative time out for prayer and your spiritual practice. Were you seeing a difference in before and after?
Correct.
I know that when I exercise, my blood pressure is better that day.
Mm-hmm.
So I see that Janet Wright asks about gestational diabetes and testing for type 2 diabetes during pregnancy and what we might do to up our game on that. And I'm wondering, since you had the most recent pregnancy, I think, among our group, in your experience with the clinical teams, do you feel like you were tested for the things that you needed testing for? And before you hand it off to Sarah Johnson, an actual practicing OBGYN, maybe talk a little bit about some greater opportunities in your experience for encouraging you to know your numbers and really supporting you with data and education. Not that you really need it, but others would.
So I do feel like I received the services that I needed. However, I did have to self-advocate. And I will say, like, I do like sweets. So it was always kind of interesting, when you would go in and, at a certain level, that's when they'll test you for gestational diabetes. But it only happens like, once during the whole pregnancy. And so, that day I did have maybe, a candy bar, something else. And I was tested, but it showed up that, there were no elevated levels. However, I just was really honest about my diet. And I really paid attention to, what I was doing. So what Janet said is absolutely right. We have to take ownership of our health management. For some, it will be easier than others, but you have to be conscious about what is your, what is your vice? If you like potato chips, if you like candy bars, you like sodas, you need to think about how much of that are you taking in and how much physical activity are you coupling with that? How much water are you drinking to kind of flush that out? What extra are you doing to reduce the stress levels? All those things that increase the risk of obesity, which contributes to diabetes, contributes to cardiovascular events. You have to take all of that information into consideration with how you choose your lifestyle. And I will say this just from a personal standpoint, but there's no perfect way to do it, but you have to take all of it into consideration. And then sometimes maybe incorporating that conversation with the physician, so then you become a part of how they're developing your health management plan. Then they can honestly determine what steps you may need to take. Because if they don't know and are trying to make a guess, it's hard on the provider also. So there has to be some sort of didactic conversation between the individual and their provider throughout the pregnancy, so that they can know what optimally to do to have the best outcomes.
Wonderful. We have so much to learn from you, and I love your story about you and your dad taking your blood pressure together. So my dream would be that women really know how to check their own numbers and carry that forward into the family at this very open-minded time in life when they're in their pregnancies and their childbearing years. So let's hear from Sarah Johnson, who has practices both at La Clinica de la Raza and also Alta Bates Summit Medical Center. I have to say, my old eyes are having a little trouble reading this. So
I got it. I got you. I can do it for you. I know it's there.
Thank you, Sarah. Thanks for talking about your experience with your young ones too.
Yeah, my pleasure. Thank you so much to Hattie and Evelyn and everyone. I'm really excited and honored to be here with all of you. As Hattie mentioned, I'm an OBGYN physician. I work at La Clinica de la Raza, which is an FQHC in the East Bay, and at Alta Bates Summit. And my passions are really aligned with our preeclampsia speaker in that I'm really excited to seize the opportunity in reproductive health for primordial and life course disease prevention for women, because we have people who are healthy and coming to the doctor and motivated to make changes. Those are my patients, and with your help, I can tell what conditions they're going to have, and I think we can do better preventing them. So that's one of my interests, and my other passion is trauma-informed care, which I think many of you are familiar with, and I've really enjoyed hearing today some of the discussion of the need to fill gaps in patient trust and patient engagement and inequity in our delivery and outcomes. And I think that I see at least a lot of synergy between this work and the trauma-informed care work. So I'm going to talk a little bit about that from a personal standpoint and also from a programmatic clinical standpoint. So personally, part of my experience that animated my passion for this was locating myself on that map of having pregnancies that showed a risk for cardiovascular disease thinking of my pregnancies as a stress test and seeing that I failed my stress test. So in my elderly primigravida, elderly multigravida pregnancies, the first one was a pregnancy loss. It was a really challenging pregnancy loss for me. It was in the second trimester. It was a twin pregnancy, so there was maybe some reasons going on, but my amygdala got connected to my neocortex and I started Googling and worrying and was thinking of everything. I looked for antiphospholipid syndrome, that was normal. I checked a ton of labs. I said, okay, it was because it was a twin pregnancy. And I became pregnant again, was happy to be pregnant, but was very, very, I think because of that experience, anxious during that pregnancy. During my next pregnancy, I kept having a feeling that something bad was going to happen with this pregnancy. And I kind of disconnected. I couldn't trust my judgment about what was safe. I thought, God, I'm just thinking this because of my prior experience. But then it turned out towards the end that my blood pressure went up. And my baby was small, 2,200 grams. So 4 pounds, 12 ounces at 38 weeks. And the placenta, boy, this scared me. The placenta was full of those infarcts that we heard about from Dr. Parikh. And I was just like, whoa, it felt like I had hit the paranoia jackpot kind of in terms of my pregnancy outcome. And I wasn't sure what was causing that, but I did take aspirin for my next 2 pregnancies and went on to have 2 healthy term pregnancies. Although in the third pregnancy, I did have gestational diabetes. So another little stress test, red flag. And this really got me to thinking, because this is kind of around the time 2013 to 2018 that we were starting to talk more about heart disease and pregnancy as a stress test for heart disease. And I started thinking, hey, what's going on with me? What kind of protoplasm situation do I have? And so I identified a couple of things. Now, of course, for an individual, we never know exactly what's going on. But one of the things that I identified, and this wasn't from reading journal articles, it was from listening to a longevity podcast, but I checked some kind of risk enhancing lipids, and I found that I have an elevated Lp(a). And that was not something that I ever even heard of in my OBGYN residency training. So that's maybe one thing. And then the other piece is something that I actually didn't connect the dots with until I started doing work in trauma-informed care. And I don't know if this is unconsciously why I was drawn to trauma-informed care, but I personally was experiencing, I later realized, PTSD when I was pregnant. And I think a lot of times we think of PTSD as sort of a war veterans situation, but women are experiencing this too. Sexual assault is very common among women and is a risk factor for pregnancy-specific anxiety, which I had, which is a risk factor for low birth weight babies. Interestingly, we don't think a lot of reproductive outcomes as being risk for PTSD, but they are. And so that kind of traumatizing first pregnancy revved up that circulation for me, I think. And then another one that's not as relevant to the general population, but that's more recently identified, is that providing obstetrical care is a risk factor for PTSD, which I really experienced because we're dealing with some pretty high stakes, challenging outcomes in a culture that doesn't necessarily support our well-being. Okay, so I didn't know, first of all, that I had PTSD or what it really looked like, nor that it's a risk factor for heart disease, but it is. And so these 2 pieces have kind of come together as what I've been able to identify for the reasons that increase my risk for those adverse outcomes. And this has really animated my clinical practice. As I mentioned, I'm passionate about trauma-informed care and a trauma-informed approach. I think many of you are familiar with this, but this is basically an approach to care that recognizes that adversity happens to people, that it affects our mental health, but also our physical health. It has really holistic effects, and that we need not only trauma-specific therapies like psychotherapy to help people who have experienced trauma, but really a holistic approach that involves the whole medical system, the providers and staff, and addresses the psychological and the physical consequences. So that could look like having all providers and staff trained in engaging patients in a way that establishes safety, transparency, empowerment. And it also means knowing the physiological effects of trauma, right? Because we used to think, oh, trauma, mental health. And now we know that through a complex interplay of neuroendocrine and immune mechanisms, stress gets under our skin and causes long-term diseases that we see in our clinics and have traditionally not associated with trauma. So we really need to connect the dots there. So that's what I'm trying to do as part of some statewide initiatives. We're lucky in California to have a Surgeon General, Dr. Nadine Burke-Harris, who's really made this recognition a priority. But I think there's lots of lessons for the trauma-informed care people to learn from what you guys are doing in cardiovascular disease and vice versa. I wanted to just show a couple slides quickly. And the first one is from the article that was the recommendations for primary prevention of cardiovascular disease by the American College of Cardiology. First of all, I see myself here. I am the other factors, the adverse pregnancy outcomes. They didn't mention here because it's not specific to women, but the Lp(a). And then this psychological factor element here, anxiety, perceived stress, PTSD isn't listed, but it's also a risk factor. And then I just want to point out that these are converging on this common pathway of inflammation. We had mentioned sort of gaps in attention and motivation. Are we preventing breast cancer? Are we addressing cervical cancer? Are we preventing heart disease? And really the scourge and the gift of modern disease is that inflammation is the final pathway for all of this stuff. So I'm thinking as an OBGYN, how can I engage my patients in a trauma-informed way in decreasing inflammation? And we can go to the next slide. This next slide is what the California Surgeon General's office has put together as evidence-based strategies for mitigating toxic stress. So these elements, and of course there are more, right? Like we don't see spirituality on here per se, but these elements all have a strong evidence basis for interrupting that neuroendocrine immune disruption that so often leads us down an inflammatory pathway that could result in breast cancer or COPD or Alzheimer's or heart disease. And these are all things that, especially when I'm taking care of pregnant patients who are so motivated for their own health and for this primordial prevention piece, which really speaks to women carrying pregnancies. These are all things we can start to bring in. And I think that the trauma-informed approach offers a lot about the how of this. We talked about people missing visits, people not wanting to engage with care. So if somebody shows up to my office and I say, well, you got to get mental health care, is your relationship good? No. Are you getting good sleep? And boy, you're not eating well, but go exercise. And by the way, download this meditation app and go for a hike. That's not going to happen, right? So we really need a strengths-based approach for engaging with our patients. So just kind of what I'll do with my patients is, I do screening for adversity and trauma. So I'll say, hey, these things happen to people. We ask about them because they're common and they affect our health in some cases, but those effects aren't inevitable. And there's a lot going on. There's a lot we can do. Do you see anything on this list that speaks to you? And we kind of go from there. And the thing that makes these hard to study, like I've seen people try to parse the interaction of these in lifestyle prediction studies. And it's like, oh, can't figure out how much of this was from the sleep and how much was from the cognitive behavioral therapy and the exercise, because they all interact. That scientific challenge is actually a gift in clinical practice because these things with a strengths-based approach really synergize. So, okay, we worked on sleep and guess what? You're in a better mood and now your relationship can improve. Or, we got you outside getting morning light, just going for a walk around the block and looking at the trees, and now your sleep is better. Can we connect? Can we use the idea of building supportive relationships as a way to help people engage with nutrition? That eating together, which is sort of strengths-based and encouraging, as opposed to like how many milligrams of sodium did you put in your diet today? So, this is a little bit ahead of the research. It's an approach from the trauma-informed world, but I really notice the synergy with what my cardiovascular disease prevention colleagues are talking about. And I'm really looking forward to sort of seeing these things come into evidence-based lifestyle management guidelines for pregnancy, so that I can, help my patients with these sort of broad anti-inflammatory tools with more detailed tools that you guys have, like what am I supposed to do with my elevated Lp(a), and kind of collaborating more across this distribution of care. So yeah, thank you. Excited to talk to you guys.
So Sarah, that was absolutely amazing. And I really love this framework. Thank you for sharing it with us. I wasn't aware of it. And I didn't know Morning Light was part of how you deal with it. But one of the things that I worry about, because I care about our Right Care family, is how much PTSD there will be for our providers who are on the front lines of these just horrific pandemic scenes. And I think it's, it's going to be something that we need to be addressing for the rest of their careers. I know that Nirali and Evelyn, the next two speakers, are co-chairs for our Silicon Valley chapter, are really experiencing a lot with caring for COVID patients. And I know you are too, Sarah. So with that, I'd like to hand the baton to Nirali, and who will then hand the baton to Evelyn. I think many of you know Nirali. She is absolutely a phenom. She's been with the Right Care Initiative since the early days now. And I'm just so delighted that we've been able to recruit her to co-chair our Silicon Valley group. So I love all of, I will just let you introduce a little bit about yourself and your experiences, Nirali.
Yeah, thank you. Thank you, Hattie, and thanks for including me again. Feel free to take the bio off. So as I think Hattie already mentioned it earlier. And so today I am really going to talk, I guess I'll touch a little bit on my own experience, but really about stroke in women as well, which is an often underrepresented topic. But we did get to cover it earlier this year as well. So what Sarah and Katrina have said really speak to me as well. I think that for me, thankfully, there were parts of my pregnancy is plural, that went okay early on. And I think that the point that you mentioned about kind of the trauma of the first pregnancy impacting the second pregnancy is really interesting. And I still, I'll always wonder why my second baby came so early. And I just sort of wonder about those things that impact us. But I think from my own personal experience, the biggest thing in thinking about cardiovascular risk, and it's something that one of our actually obesity speakers mentioned earlier in the Right Care Initiative, was just how women go through life, and this peripartum, postpartum time can sometimes be a major life-changing event with weight gain that is actually going to increase cardiovascular risk to such a great extent. And it's something I've personally experienced with my postpartum pregnancy weight. And really, when kind of finishing up with the OB care, didn't really have that picked up by anyone else. And as Katrina mentioned, and as others have mentioned, have really had to advocate for myself in thinking about how I'm going to address my care and address my primary prevention in this postpartum time where, a young woman would not traditionally be screened as at high risk for cardiovascular disease, despite me being South Asian, despite having this increased weight gain and all the other components that affect a woman after pregnancy. And so I think that has been really interesting. And I think someone mentioned Noom and like these other apps that are kind of supporting behavioral change. But honestly, the only thing postpartum at the postpartum follow-up was like, are you depressed? If so, let me send you to a psychiatrist, but never what you mentioned, Sarah, which was here, like, let's think about this holistic approach to thinking about mood and to thinking about how that might be impacting, weight, et cetera, et cetera. And so I think that having that integrated model and some kind of handoff, if you're not going to see the OB any further, but back to the primary care is really important. And it would be great to kind of hear in the discussion portion, what is currently happening and what is the interaction between the OB when the postpartum care ends and the primary care that a woman needs to keep her health going, where maybe the postpartum care is no longer, the person responsible for postpartum care is no longer responsible for the life in general of the woman. So that was sort of one question I had. And then as far as stroke and women, I think, what Katrina mentioned is really important, right? even though stroke has dropped to the 5th leading cause of death in the United States, it's the 4th leading cause for women, double breast cancer, and it is the 3rd leading cause of death for African American and Latina women. So there is still this prevalence of stroke and higher stroke mortality in women. And I think that as a trainee in stroke neurology, and probably many of you have often thought and been taught that male sex is a risk factor for stroke. And even though there are epidemiological studies that support men having more strokes than women, the reality is women live longer and they're actually more prevalent to have strokes, that stroke is often the first presenting symptom of cardiovascular disease in women as opposed to men, who may present first with like a heart attack. And that it's really interesting when you look at data, stroke outcomes are worse in women than in men, even when you adjust for age, because it is true that it's older women that often have more of these strokes. But when you adjust, it looks like women are still having worsened outcomes of stroke. And why is that? And so people have done a lot of epidemiologic studies to try to understand this. And one of the factors that was found was pre-stroke disability being one of the things that contribute to that. And this, I think, ties back to getting involved earlier in a woman's life to understand how do we protect that woman from developing disabilities that will potentially basically close the door on endovascular therapies, for example, in stroke, that often look for a woman who has a great baseline, or a patient that has a great baseline before getting treatment. And the other thing that's common in stroke as you get older is that it's actually women are having more cardioembolic strokes, or strokes from atrial fibrillation. But we know the treatment for atrial fibrillation is anticoagulation, blood thinners. And because women may be thinner or more frail, they don't get that treatment. And so, like, even though we're talking about older women having these impacts, it all starts at a much earlier time. And I think that's the whole point, that we're pushing this lifespan discussion earlier and earlier. And so that was one major point I wanted to make. And then finally, the point about preeclampsia that was mentioned. So it's true that women that have preeclampsia or higher blood pressures during pregnancy, they have I think there was one study that showed a 14-fold higher risk of stroke in the subsequent 3 years. And why is that? And I think someone made that comment, like, what is, again, the follow-up for someone with gestational diabetes or preeclampsia? Who's then checking to see if these women are developing diabetes or hypertension at an earlier age after their postpartum care has ended? And so maybe I'll, before we move on to Dr. Stuck, maybe I'll just ask Dr. Johnson really quickly, what is the obligation of the obstetrician in a woman who's had gestational diabetes or preeclampsia to sort of sign out this risk or to manage this risk moving forward?
Yeah, I mean, I think the obligation is there and it's not often seized upon. We're trying. So it's recommended, for example, that we tell women with gestational diabetes that they're at risk down the line, and that they get checked 6 weeks postpartum, and then that they get checked at least every 3 years afterwards. But if the patient doesn't come back, how do we know? We're trying to do things like put this in the problem list, for example. We hope leveraging the EHR will help. And then another development that's encouraging, if it's seized upon, is the kind of visualizing postpartum care as more of a continuum extending for a year. So that's been put out by ACOG as what we should be doing. And then it's reflected in new legislation in California under which Medi-Cal recipients will be covered for a year after, because who cares if we're supposed to do it if coverage drops off at 6 weeks. So, then though you have OBGYNs are doing a little bit of hot potato with this cardiovascular stuff. And are not, like, I love this holistic model, but I can't say that I'm speaking for all of my colleagues. So I think we need to have better conversations. I know there have been studies done though, where patients are satisfied, like at Mass General, I think they have a kind of warm handoff clinic that's trying to decrease the barriers for this kind of thing. So everybody with one of these adverse pregnancy outcomes related to hypertensive disorders gets transitioned to this internal medicine clinic where they handle everything. And that might make it more streamlined, right? Because it's like, oh, which doctor are you going to? Do you have an internist? I don't know. Come back to me if you have questions, but I don't really know what I'm doing. So I think there's this kind of bumbling thing that we need education and systems to address.
I think re-envisioning the models of care and innovating is exactly what we do here at Right Care. And so it's really exciting to hear that ACOG is supporting some of these models. And, you know, when we open it up to the group, feel free to put it in the chat if you're aware of models that kind of do this. But I definitely think that for all the data out there on stroke, there's young stroke, and I didn't even get into all the stroke, you know, risks that happen in the pregnancy timeframe about clotting, et cetera. But even for the most common issue, which is stroke later in life for a woman, having the woman be healthy now to prevent those strokes and also increase their access to care later on is so critical. So with that, I'll pass it over to Dr. Stock, my fearless co-chair and cardiology extraordinaire, who studies metabolic disorders, as she's an endocrinologist as well as a cardiologist. You can see her bio here, and I'm hoping she'll pick up on what Dr. Johnson mentioned about lipoprotein little a and other aspects of care. So please read her bio, and then Dr. Stock, take it away.
Yeah, thank you, Nirali. Well, all of this has been so interesting, exciting, and it's very dear to my own heart as a preventive cardiologist, and continuing to research on the metabolic underlying mechanisms that promote or protect from cardiovascular disease. I am a fearless advocate for all of the lifestyle measures, and that's where I start my conversation with my patients, and then we move on to uncovering the various molecules and advanced lipid markers. So I am so excited to have these models that we can use now. Thank you, Sarah, for showing us sort of a way to frame this and look at it. About LPA, I don't have a slide on that, but I just want to tell you how important this risk factor is. If you have a dyslipidemia, meaning low HDL, high LDL, high VLDL, your LPA risk increases your cardiovascular risk by 25. If to that you add two risk factors, like say hypertension, diabetes, cigarette smoking, high homocysteine, it increases by 122. So the synergistic effect of this molecule is huge. It is an underappreciated risk factor that we could detect very early on. And I am going to talk about a little bit about putting LDL as a very well-studied molecule in the front, because Lp(a) came very late to the dance because it was very difficult to measure. So there were many studies done for many years. And if you don't have a good measurement, you can't get good statistical analysis or define anything. So that put LPA in the background. Nobody really knew what it was. Nobody knew what to do with it. And now finally we get this inhibitor, antisense oligonucleotide, that we're testing in clinical trials in people who are very high risk, and we're going to have results hopefully soon if COVID lets us recruit any patients in this trial. So we're a little behind on that. Regarding its use in pregnancy, well, in my own life, I had two pregnancies as a geriatric, also pregnant woman, right? I was considered high risk, and I fought it with tooth and nail. Despite my Hispanic heritage, I kept, you know, my same weight throughout my pregnancy. And of course, everybody at home, my grandmother, my mom, what are you doing? You've got to gain weight, more weight, more weight, more weight. And I was walking from the marina to Mission Bay every day pregnant. And I kept walking, sort of trying to prevent, I have very bad family history of cardiovascular disease, diabetes, all kinds of complications in my family. And I said, I'm not going to have that. But I think I went a little bit overboard, and, I think that stressed me out a little bit too. So I was lucky to have 2 normal kids, but I feel that, there's a lot of pressure from family and community to gain weight during pregnancy, to give you food, to, treat yourself, or, you shouldn't be walking. My mom would call me every day, you're walking again. You've got to stop this. This is not good for you. So fighting these, I would say, misconceptions of what you can or cannot do as a pregnant woman is difficult sometimes, because you're fighting the community that has their own ideas about what you should eat or not eat, or what you should be doing. And primary care was not helpful, and my OBGYN was just cheering me on, which was very, very, very important for me. And I put this slide here sort of to draw your attention to a newer concept of how we view cardiovascular disease in general. I put LDL as the, poster child, because there's so much data on it. And you see right over here, each color sort of represents a different population, right? We have a different population of patients, and you're plotting cumulative low-density lipoprotein versus years age. And this line, the dotted line that is parallel to the x-axis, is the threshold for the onset of cardiovascular disease. So you see that people who have severe hypercholesterolemia from birth, so these are very high cholesterol levels very early on, they develop cardiovascular disease very early on. The earliest I've seen a heart attack in a familial hypercholesterolemia patient was 11 years old. And then you see people who don't have such high levels with moderate hypercholesterolemia starting in their teens. Either they have the genetics plus the unhealthy lifestyle, and they develop, they accumulate LDL, or equivalent to what we would call like pack years when you're smoking, that sort of concept throughout life. They have early onset cardiovascular disease. Then when the hypercholesterolemia develops later in life, you have much better outcomes. The age moves towards older years. And then if you have excellent genetics and lifestyle, and your LDL cumulative effect is low, you might go throughout life without experiencing any of these adverse events. Next slide. Here is a slide where I'm trying to give you an idea of the other side. Maybe go to the next slide before that, because that one. So this is a slide from a newer study from the cardio study group. These are young, healthy adults that were studied from age 18, followed until age 40. And then at that age, they followed them for 16 years to see their cumulative LDL throughout the period that they were studied. And they had these different cohorts where the upper quartile, that is there in blue, had the most exposure to LDL cholesterol. And you see how the cardiovascular disease event rate starts diverging very early on. So these are people who are very high risk. Mind you, all of these were healthy people at the beginning. And then you see that the different quartiles represent lower levels of cumulative LDL. I thought this was interesting, and it shows you how early exposure to high cholesterol levels and possibly other risk factors is puts you sort of on a track for life, right? And so we need to act early. And this concept of, getting people midlife and then worrying about cardiovascular risk prevention might be quite a lot late to the game, right? Because you've already developed the underlying biology that will just continue throughout your life. And then if we can go back to the prior slide, I wanted to talk about HDL and the misconceptions about this molecule. So traditionally, it's viewed as a vehicle to just transport cholesterol out of the body, right? It's like this dump truck that gets the cholesterol and brings it out to the liver, and then out it goes. But it's so much more than that, right? We know that the HDL level is not a good predictor of function of HDL. HDL has functions in inflammation. It is very close to the immune system and modulates the immune system. It transports molecules, over 200 proteins on its cargo, I would say. And it's a very plastic molecule. It gets remodeled throughout life and acutely and chronically under inflammation. So it is both a modulator of inflammation and gets modified by inflammation. And the effects are quite complex to study because they're different. If you have acute stress, let's say sepsis, this molecule gets all excited and it helps bind the toxins and it fights off the bugs and it gets you healthy. In chronic inflammation, this molecule suffers remodeling and might be dysfunctional, being pro-inflammatory. So instead of helping you improve endothelial function, improve vasodilation, it does all the wrong things for you. And it's modulated. It has receptors in the liver, in the endothelium, and in different tissues, and it does different things in different places. So I don't want to bore you with all this functional stuff, but now we have the means to start acting on these inflammatory cascades. The CANTOS trial was the first one where we have evidence that blocking, the interleukin-1 with this antibody improved cardiovascular outcomes, and interestingly, also improved lung cancer, right? So it gives you insights how inflammation is involved not only in your cardiovascular risk, but in your risk of developing cancers and how fast those might kill you, right? We're having new targets to modify HDL. We know that all of the trials that increased HDL levels belly flopped horribly and increased cardiovascular risk and had worse outcomes. We think that's because HDL is complex. If you're blocking HDL with CETP inhibitors, for example, that was the way that they were doing, blocking the the removal of cholesterol by increasing this HDL artificially, it just did not work. So now the focus is into finding out what changes the HDL cargo and how we can improve its function with, the things that Sarah had in her nice diagram, including sleep, good eating, stress reduction, and all of these things. We also have inhibitors of ApoC3, and now we have modulators of ApoE. So we're going to be seeing new kids on the block coming in, and it's going to be very exciting. For women, the most important message I want to throw out there, HDL levels do not equal function. So if a woman has elevated HDL and a family history of cardiovascular disease or stroke, please do not just pat her on the back and say you're fine, because a lot of those women who have very high HDL levels, let's say above 90, above 100, those are dysfunctional HDLs. Those women are at increased risk. So it's very important to look at the other risk factors and maybe get, some calcium score or a lipoprotein A. I was going to bring a patient of mine to speak. She is a very dynamic woman, very amazing attorney, and she is thin and active, and she had very high HDL her whole life. She kept going to the doctors telling them, my dad died at age 50 of an acute MI, and my mother had a stroke, and I feel like I'm at risk. And they would always pat her in the back and say, no, you don't have nothing, go back home. And then after years, she came to see me because she had angina, and her calcium score was 1,200 and a very high Lp(a). And at this point, the basis of her cardiovascular disease are already established. She has severe calcification, and we've had a heck of a time getting her symptom-free. So finally, 2 weeks ago, she is symptom-free, and she was very happy. And now she could, she was going to come and talk to you all about this very important challenge of recognizing cardiovascular disease risk. So next slide, and then the next one. That one, I thought this was amazing. So this is the first real clinical study that was recently published, where it shows the high-density lipoprotein anti-inflammatory capacity and the incidence of cardiovascular events. So this took the PREVENT study, which is the prevention of renal and vascular end-stage disease cohort, and measured HDL cholesterol, high-sensitivity CRP, and they measured by a very fancy laboratory assay the efflux capacity and the anti-inflammatory capacity of the HDL, its ability to inhibit TNF-alpha. And so what they saw is they added these scores to the Framingham risk scores, and they got this curve that I'm showing you here. So you see the anti-inflammatory capacity where it says 0 is sort of where that flat line ends, right? And when the anti-inflammatory capacity starts to increase towards the right up to 70, you see a decline in the probability of cardiovascular disease events. This was absolutely independent of HDL level and CRP level. And when you look to the left, where the anti-inflammatory capacity begins to decrease, the upper line, that's the composite risk begins to increase. So I thought that was neat. This is the first clinical evidence that we have of this. I think we're going to see a lot more of this as we have a better ability to predict the anti-inflammatory capacity. In our lab, we ran cytokines routinely in plasma from our patients, and we've developed these sort of signatures of risk. And we're seeing very important differences between men and women regarding HDL anti-inflammatory effects. The effects of this inflammation seem to be more pronounced in women, and the efflux capacity also tends to have a mild increase in cardiovascular risk, but is beyond that of men. So there's also evidence of the PCSK9 inhibitors that I just want to let you know that those drugs have been very effective at lowering LDL. And I want to sort of give you hope and encourage you to use lipid-lowering treatments early, prevent with health behaviors like here. We heard a lot about primordial prevention. I think people are getting it. They're knowing that we need to act early. So fetal and infant health, smoking, high caloric diets should be, patients should be cautioned, people should know about them. Physical inactivity, environmental pollution, we didn't talk about that, but there's strong evidence of environmental pollution accelerating the effects of, you know, these risk factors on your cardiovascular outcomes. And the lessons that we have from these PCSK9 inhibitors are very important, I think, because they point out how you can go from an observation of a population in which they had very low LDL levels. They had these mutations in PCSK9 where these group of people had very low incidence of cardiovascular disease. They were not exposed to elevated LDL. And this observation led to the development of these PCSK9 inhibitors, and then the outcome trials came pretty soon after. I would say the first one was the Fourier trial that taught us that lowering LDL improved outcomes in people who were very high risk, already treated on a statin. And what I find most interesting about this trial is that the lower quartile of people treated with this had an LDL lower than 19. So 25% of people got there, and they had very good cognitive evaluations. That's what worries our patients. They say, please don't put my LDL so low, I can't think, I can't. And that's fine, but as clinicians, you know, I always tell my patients, if you think you're having a side effect, just tell me, and we'll go low, and we'll see how you do. And most people tolerate them well. They also looked at incidence of diabetes and other side effects. So I think if you can start to run clinical trials, keeping in mind, you know, the things that patients are worried about, which is, will I become a diabetic with this? Will I lose cognitive function? Will I have a worse life on these therapies? And then you can give them the data and say, no, you won't. This is what happens. I think that women would be more likely to be receptive to these treatments. We're always very scared of side effects, which is absolutely needed and right. But as clinicians, we should also be empowering our patients to try out certain therapies maybe and to adhere to their health behaviors. I'll end it
Thank
there.
you. Thanks, Evelyn. That was awesome. And I think you brought up a really good point there right at the end as well, that, you know, when, especially when we were thinking about the postpartum population, how there is, I mean, I think a lot of us probably experienced that. Would we really want to be taking new medications while nursing or while, you know, being responsible for the other child? And so I wonder if some of that may impact health behaviors of wanting to follow up on things like just, you know, gestational diabetes transforming to diabetes or preeclampsia transforming to hypertension. But I guess we have 15 minutes for Q&A, and I just want to thank again all the speakers for their input. Sorry that I came late after clinic, and for people for sharing their stories. I put kind of a chat, you know, question for all of our attendees to respond in case there are cool or innovative ways to take this low-hanging fruit of women who are at this high risk and vulnerable period and get them care. And I appreciate Dr. Yu and Wright's comments about, you know, getting them back to the PCP. And I thought that was really fascinating what Dr. Wright mentioned about, you know, can we just check for diabetes 2 days postpartum? Why wait till like visits and prolong? So maybe I'll start by asking Dr. Johnson the answer to that question. Can we just do postpartum, you know, A1Cs at day 2? And then hopefully I can take a look at the audience while people raise their hand or put questions in the Q&A, which will be probably the easiest to facilitate. If you can type your question in the Q&A or the chat box, I'll look at all of them. Go ahead. Dr.
Cool.
Johnson.
Yeah, I'll have to check out the article that Dr. Wright's referencing. I need to do my maintenance of certification articles, so that's one I'll read. But yeah, I think it probably is not the A1C, just because red blood cell turnover is higher in pregnancy, so the test isn't really validated. But I bet that they're talking about like a glucose challenge. But when you have somebody as a capped, I mean, I wonder what the women thought of that as people are like rounding on them at 5 a.m. and they're being poked and prodded, and now drink a glucose challenge test. But yeah, I bet that there's higher uptake there. That's a really interesting notion. I'm curious too, just thinking about this connection to PCPs. Do PCPs need to be educated? I'm guessing yes, about the significance of these pregnancy outcomes for future cardiovascular risk. Because I feel like when I go see my PCP, who's very nice, but he's always like, you're young, you know, you're not old and sick. So I have to kind of, like I had to really pound the pavement to get my Lp(a) checked and to get a coronary artery CT scan. And then my score was 0, and they were kind of like, okay, well, come back when you're sick. So, you know, I don't know, like PCPs might need a little help too. Like we need to collaborate in terms of how to take care of these currently healthy, overwhelmed people.
Do we have any primary care physicians in our audience that might be able to comment on that? I know Dr. Yu had to step off. Feel free to raise your hand and we can promote you or unmute you somehow. Feel free.
So we do have with us Ron Scott, and I don't know, Ron, if you can unmute yourself and talk about how Kaiser handles this transition. We did promote, so Jenny, who has the capacity to promote people, I don't really have that technical knowledge, had to pivot away. So we figured we could just do Q&A now. We do have some of our other leaders with us on this panel who can feel free to put their videos on and to address that experience in their own health systems. I can try to monitor the chat, but I think it would be, I just want to say that the issues that are being raised by our women's cardiovascular and stroke group are just so important. And we need to come up with a different workflow. So I don't know, Nirali, whether you might be able to engage the Clinical Excellence Research Center on this. I know that Bob Kaplan really wanted to have Mark Halatke, who is also there at Stanford. I think he helps with the Clinical Excellence Research Center, to talk with us about preeclampsia and needing to improve women's cardiovascular care. And I thought that it would be better to have women talk about it. And I thought today was really eye-opening. What an amazing group of women to be able to work on sort of a care path improvement. It seems like some of the ideas that we've discussed in our group should really be implemented. I mean, every woman should be outfitted with the skills to do home blood pressure monitoring and take that into the home and teach the whole family, make it the culture, change the culture. We should not accept the status quo.
I think, yeah, I don't know how CERC selects their areas of focus or their topics, but I think, you know, this transition and young adult women is a great area. I wonder if our representatives from Department of Public Health, Jessica, Katrina, I don't know if they can comment on, from a system standpoint, is this an area that's actively kind of tackled from the Department of Public Health? And, you know, what innovations are available, what education is available for primary care?
It's something we definitely are encouraged to support. What I can tell you is this is a lot of the reason we have this very Right Care University of Best Practices dialogue, because sometimes it's not enough to have the research that shows what we need to do. You have to kind of build in by getting that kind of groundswell, that grassroots, the evidence, and then we work, for 20 years, 2 decades to get doctors to adapt it. And often you teach the medical students that then put it into practice when they're doing the work. So any way we can leapfrog, I'm open to. And the truth is that we, and why I made the announcement about the update to the action plan, is we as a group, many members of which will be on our steering committee from this organization or this group coming together, can decide what we want to do and where we want to focus, and do less than 400-page document about everything and everyone, and maybe hone in on a few things we want to see. So we're open to it, and would appreciate any ideas, because we're here to very much do better than we've done. Katrina, did you want to add anything?
Okay, so no, I think you did very well in your response.
Thank you. Thank you, Katrina.
Very supportive. Other comments or thoughts from our panelists, or I don't see anything in the Q&A or chat box at the moment, but we have our last 10 minutes here.
I would be really excited too to kind of break down this mind-body connection barrier. It's not like preeclampsia is cardiovascular disease and depression sees psychiatry. Like, depression is also a cardiovascular risk factor, and it's this lens of inflammation, I think, that that Dr. Stock was the first, she's my neighbor actually, and I get to go on walks with her and hear this kind of like, let's think about, I could picture like my Lp(a) interacting with my traumatic stress. And like, of course, inflammation is the same as trauma because it's about keeping ourselves safe. This like getting this, I don't know, it might be hard, but getting this concept into the public consciousness. Most of my patients speak Spanish, and they think I'm talking about bloating when I say inflammation. So maybe it's a bridge too far to have the public understand inflammation, but that's the modern disease scourge. So can we break down this silo situation?
Yeah, I think linking, just diet in general to all, I mean, this is what we talked about in our working group, to all the outcomes from brain health to postpartum motherhood to heart health. The common, denominator can be like these dietary improvements, and framing it through all of the benefits, not just cardiovascular benefit, is totally.
And for social justice and climate change. I don't know if you like public health people get to talk to, like the FDA and the USDA.
Well, I'd
So
like to just
I
say
have to
something
just-
real quick before
I
Hattie, because
just
I
wanna
know
say
Hattie and
one
I are of
thing.
the same mind. Real quick. What I want to say, number one, is Sarah, I was really struck by your story, I just think that's so, my heart went out to you in terms of what you experienced, and the fact that you're willing to talk about it and to make something happen is just phenomenal. And that it's your daily work, and that your daily work causes you post-traumatic stress, and yet you're still willing to be in there. You're a warrior, and I'm just like, I'm in awe. But that being said, I think the way you described it is really something that people can appreciate, and that it's these simple ways that we as women in this conversation with these supportive men and so forth, they're talking about women's heart health and the younger group. It's these kinds of connections that will get the public and patients to really understand and actually do more than kind of the way we've been approaching it in the past. And what I can commit to you right now is that we are doing things differently in the department. COVID has really underscored all the concerns that you've raised for all sorts of people, and we are going to take a different approach in our department. We are committed now with Dr. Eragon to health equity. All the things you're talking about is where we're going to go. So I don't want you to come and feel that, wow, what I'm talking about is different. It's humane, it's social justice, it's all these things that we don't typically do. Well, but in public health, we do it now. So, and we have the support. So I just want to put that out there, because I don't want any of you to feel defeated. I want you to join us in this important work, because it's going to take all of us. Thank you. Hattie, back to you. Sorry.
I just want to encourage people to think from the standpoint of the less educated patient and the super stressed out mom who has, maybe is working and has multiple children and maybe doesn't have a super high education level. And I forget who said it, but you have to, I think it was Nerali who said, you've got a patient who, maybe they are depressed, but if the doctor then says, well, I'm going to refer you to psychiatry, a lot of women would never go to psychiatry. There is such a stigma to that. And they also just generally, and I've told this story to many of you in our work groups, et cetera. I mean, my mother was a national security mom, fluent in 7 languages with 4 teenagers and a heavily stressful job and a sick dad. She was caring for her dad, who was hospitalized the day that she had her stroke that killed her at such an early age. But if you think about the amount of stress that women in those sandwich generation years are going through, I don't think we have good answers for them culturally. And to just say, well, you should take a walk in the sunlight and get a massage and eat better and so forth. It's like, are you kidding? I'm just trying to get dinner on the table. And I'm just trying to get my, sick kids to get their medicine. I mean, women are not really thinking about their own health in those years. I don't have easy answers. And in the Right Care Initiative, we like to say, here are practical solutions. And I think we have more work to do as a group to come up with more practical solutions. I think one of the best ideas that emerged from our discussions previous to today is the healthy mama gives you the healthy baby. So if we can start training women that in order for your baby to be healthy, or in order for your children to be healthy, we need you to be healthy. And here we need to support them. We need to give them tools. I think the best investment would be, you know, blood pressure monitoring at home for all women starting in their childbearing years. So then they can at least bring that sort of practical caring mode at home. And if they start testing their blood pressure when they're 30 years old and they make that a tradition, maybe make it a Sunday family tradition, we're all going to test it, then maybe someone like my mom, who never went to the doctor other than to take her kids to the doctor, might not have perished because she would have known she had high blood pressure before 2 months before she died. So I think we need to completely reconsider what our expectations are of especially working women. There aren't a lot of stay-at-home moms now. So Jessica, I am just thrilled that you were with us to hear all these perspectives, and that you're well positioned to bring in the other big thinkers in the state government, from social services, et cetera. I mean, probably peer support groups, peer walking groups is going to go over a lot better than any sort of a referral to psychiatry, you know, any formal. I think women will reject that. They're kind of too busy to go to the doctor. Would love to hear other people's thoughts.
Well, I also note that it's getting close to 6:30, Hattie, but I wanted to acknowledge Dr. Alarcon's comment in the chat as a primary care physician, how, you know, even when a patient comes 1 year postpartum, it's already kind of delayed and that energy is gone. And how we need OB, we need that kind of collaborative models to get the ball rolling, that then the PCP can take off, because the women are too busy to go right away jumping to multiple physicians. So I think, I know I joined late, but while there are great plans for collaboration with CDPH and others, and the great big, you know, plan we will devise and innovate together, the very low hanging fruit seems to be this point that can easily be adapted, I hope, to the OB kind of PCP transition. So I'm really happy that Dr. Johnson is in this group now, and will keep innovating with us together. Lots of great ideas. Shall we wrap up, Hattie?
I think we should. We'll just invite people back to our next discussion, which actually has a lot to do with how we can support these women. So on Monday, October 11th, from noon to 2 o'clock, we are going to be discussing healthy nutrition choices. We're going to have Gita Saikand, who's the head of the nutrition section for the National Lipid Association. We'll also have from the U.S. Air Force a discussion about how to lower fatigue, increase sleep, strategies from a behavioral health standpoint, more self-care standpoint. And I see that we have Dr. Sky with us, and he has introduced us to Dr. Smith, who will be bringing that important research to us about how do they practically implement that in the Air Force for the men and women who serve to help lower the constant sense of fatigue, especially in the frontline healthcare teams. And my goodness, I'm just so moved by all of your, you know, energy and brilliance and experiences. And I think it's an important role of the Right Care family is to be a support group for each other, because people are just very siloed. And, you know, to have an OBGYN now talking with a neurologist, now talking with a molecular cardiologist, epidemiologist with the state, that's how the Right Care family has been successful in building change, is that it's a collective mind that we learn from each other. No one of us has all the answers, but together we have strength. And on that positive note, I'll just say namaste, thank you, and we'll see you in a couple of weeks. Good night.
Bye, everyone. Thank you.
Thank you so much.